Right, so now I should be recording, so if anyone is coming in late, sorry, they'll have to watch the recording bits they miss. But yeah, so this is leukemia. So like I just said, kind of meant to be a bit of a follow-on from the lymphomas from last week. Leukemias, you do tend to like hear more about and see more of in questions and stuff. And yeah, I hated them last year, so I think part of the reason I wanted to teach this is because it's useful for me to go back through. So again, with last week, I sort of tried to teach it in a way that was probably more in depth than you need to know at finals level. So just pick and choose what you want out of it. But I kind of thought I prefer, if I was in your case, to just have a lecture as though like you were still getting content from the med school, and then you can break it down if you want to. So if you're like reading things and you're thinking, that's like, I'm never going to remember that, don't worry too much about it. I think the main things for the leukemias are sort of to know the importance of like the pathognomonic features, to be able to differentiate them. And I'm going to try and show you a few little hints and tips where that's possible. I've done it case-based again because that seemed to work quite well with you guys last time. And I can actually see your chat this time. I've managed to make it work. So if anyone has any questions as we go through, try and ask them. I'll try and answer them. But yeah, with the cases, I've taken them from like a few ones I found online and then added a few bits in that I just thought, not necessarily saying that that's what you typically see, but like features where I was like, okay, if they were going to ask a question, that's the sort of thing that they might throw in there just to sort of make you think this is the particular disease. So let's get going. So like the broad introduction. So leukemias are another of the ranges of hematological malignancies, the others being myeloma and lymphoma. And we tend to divide them into acute and chronic and myeloid and lymphoid. So if you put that as like a sort of table of 4, which you can see on the left there, that is roughly how we classify them. There's lots of like categories of them, don't worry about those. They're not that common. You get about 10 in 10,000 per year. We always see things on TV about like the children that are going through like these really horrible cancers and things. If anyone's familiar with like Anthony Nolan Foundation, stuff like that, they tend to be children that have got acute lymphoblastic lymphoma. And then you've got the more chronic ones. They're more common in elderly people, and chronic lymphocytic lymphoma is your most common one of the 4. And they all share like a similar set of risk factors. So you're looking at exposure to radiation, chemicals, drugs. So that can be people that have had like occupational exposures, people that have had previous radiotherapy and chemotherapy, or lots of like CT scans, MRI, whatever, stuff like that. And then there's certain genetic syndromes that we link them to. So in particular, trisomy 21, which is Downs. There's increased frequency amongst monozygotic twins. So if one twin has it, there's a higher chance the other one will get it. Syndromes like Li-Fan-Meni syndrome. Certain viruses, there's one called HLTV1, which I don't think I ever have learned about before in med school, but it comes up. And then HIV, because that does increase your risk generally of all cancers. And then Myelodysplastic syndromes, which we're going to cover today as well. And remember, like the treatment for it involves suppressing bone marrow and also suppressing the immune system. And from that, there's other negative consequences that happen with the treatment. So not only are they pretty nasty diseases, they have pretty nasty treatments as well. So overall, like not the most fun of diseases you're going to learn about, but it comes up quite a lot too. So there's going to be a lot of like symptoms and things that I throw at you today, but broadly, when you're thinking about this sort of these diseases, the core things to remember are just that like something's going on in the bone marrow, and because there's overproliferation of one particular type of cell, usually, whether those cells are blasts or the mature ones doesn't really matter. They're going to compromise the other kinds of lineages that are made in the bone marrow as well. So from like this picture here, which I think is from osmosis, if anyone wants some video recommendations, recommend the osmosis videos. But this kind of illustrates very well that you've got, from your hematopoietic stem cell, you've got red blood cells. And obviously if you cut your supply of them, that's going to lead to anemia and its associated signs and symptoms. Cut your white blood cells, your immune system is going to take a hit. Cut your platelets, you can't form clots as well. So you're going to get simple things. If it's not like mad, it's going to be just bruising, petechiae, things like that, but also increases your bleeding risk and hemorrhage. So there's like a bit of a scale that can cause. So if you're thinking of like 3 core things that bone marrow suppression is going to lead to, just think of it systematically as like the cell types that you're getting cut. So case 1, if this will move. No, not case 1. Investigations. So the investigations generally for like all your leukemias, before we go diving into the different types, history and examination. I think people should say this to you like every time you're having this kind of lecture, like they're the most important things when you're trying to get a bigger picture of what's going on with the patient. Full blood count, obviously, because they're hematological conditions. Anemia being one of the symptoms. So anemia, I'm hoping next Wednesday, I'll ask you at the end, but if this is the popular vote, we're going to try and break those down. So we'll go into that more another time. But your investigations for anemia, you want to consider things like B12, folate, iron studies, just to rule out if you're getting a bit of a vague presentation, because a lot of these cancers do, as much as they have like their key features, they do present quite vaguely in reality. You just want to rule out that there's not something else going on as well. And sometimes you can have like, just because you've got one diagnosis, don't assume that there aren't other ones being masked by the results that you're seeing. Blood film, bone marrow aspirate, they are a must. And then there's all these fancy laboratory-based things that you can do to assess what the cell markers are, what the lineage is, whether it's myeloid or lymphoid, for instance, and look at how bad it is. And leukemia is one of those sets of conditions where there's quite a lot of key prognostic markers which confer whether you're generally going to have a better or worse outcome. So the classical one that you get is this Philadelphia chromosome, which it's translocation of 22 to 9 or something like that. It doesn't really matter, but you get it in like most CMLs and some of the ALLs. So if you're thinking like of an association there and you see Philadelphia chromosome, you're always going to think CML generally. And also, because this is a cancer, if you're seeing increased uric acid and increased LDH, you're thinking there's a greater tumour burden, we've got more cells reproducing, replicating themselves, and they're poor prognostic markers as well, because the higher they are, the bigger the tumours get, or the more tumours you've got, basically. Sorry, my computer's decided it's not going to move. There we go. So first case, so we've got a 71-year-old man who presents to the GP with generalised fatigue that's progressed over several months. When you examine him, you notice pale mucous membranes, skin pallor, and mild tachycardia with no else of note. He has not noticed any increased bleeding, but he does believe that he's had more colds than usual this last year or so, having otherwise always been fit and healthy. You send off for a full blood count, and it returns with enormocytic anemia, neutropenia. Iron, B12 and folate studies all return normal. His bone marrow aspiration levels reveal dysplasia with high cellularity and about 5% blasts. So if you go back to the video that I did last week, we went over, I think I may have touched on what cellularity was. If I haven't, I've got a little thing where I've written something up about that I need to send out to you guys. But yeah, so key things on this case. So you've got an older guy who doesn't seem to be particularly bleeding, but he is thinking, actually, I'm getting a bit more ill than I used to. So instantly we're kind of thinking, are his white cells down? Have they been down for a while? And he's got this normocytic anemia going on, which is something that actually, like, across most of the leukemias, they do tend to present with a normocytic, normchromic anemia when they come back. But again, like, we'll touch on this a little bit next week if we do anemias. And blasts are something that we'll get onto again a little bit later, but you'll notice that they're there. They shouldn't normally be there in health, but he's got a bit of a small count of it. So this is kind of starting to make a picture for us of, when it loads, the myelodysplastic syndromes. So myelodysplastic syndromes, like, they're a really vague one that I struggle to get my head around. I think the reason why is generally there's not really a lot to know about them. If you look in most textbooks, it will just give you like a small paragraph, and that's fine. So really just think of them, if anything, as like a risk factor for progressing on to AML. So there are a bunch of conditions. I think there's about 8 of them that the WHO recognise, and you don't need to know any of them specifically. But most of them occur primary. Sometimes they can happen because you've got a patient that's got a background of having chemo or radio in the past. And you basically just got this kind of like, your cells are starting to get a bit dysplastic. The clue is in the name, in the bone marrow. So you'll have some blasts, but you're not going to have over 20%, which is where you start to get your cut off for it being an acute leukemia instead. So I wouldn't worry too much about it. I would just think of it as being a precursor to leukemia if you ever see it as an option in a question. But it's kind of that, the blast percentage, which is what you want to be looking at when you're thinking, say if you've got a multi-choice question, it's giving you the option of AML or a myelodysplastic syndrome, look at that percentage and look at, are they saying, are there any of the pathognomonic features of AML there, for instance, which we'll be covering in a couple cases time. So yeah, generally the symptoms you sort of get with it are just the symptoms of pancytopenias, so like bleeding, infections, the things that we talked about on that side when we were breaking down the different things that you get when you're out of red blood cells, white cells, etc. Because there's such a range of conditions, the kind of the survivability of it is very varied. It depends what it progresses onto and how quickly it progresses, and the more blasts you have, the worse the prognosis. So generally, like if it's not that bad, if it's quite low risk, we're just going to monitor it, do watchful waiting, and if it's a bit like more severe category, if the percentage of blasts are higher, you might consider doing transfusions, giving red cells and platelets when the patient needs. You might give erythropoietin to stimulate some red blood cell production, and consider stem cell transplant, and it's curative. But the thing with stem cell transplant, because this again comes up a lot in leukemias, is that it sounds like a wonderful thing, but it's not well tolerated by patients. So generally you don't want to do it in old people. The risks of it are quite high. So it's like, yeah, we could do it, but is it worth the risk? Can the patient tolerate it? And also you need to have like someone, like generally it has to be HLA matched and stuff like that. It's not quite as easy as it sounds on paper. Cool. So moving on to acute leukemias. So we break these up into ALL and AML, and you can kind of see, again, like there were a few pictures last week of blood films and things like that I showed. They would be really, really, really mean if they ever actually got you to look at some slides and analyze them, because you're not hematologists, so why would you be doing that? But you can see in the picture on the left just how blasts are like these much bigger immature cells. I don't know what it is that makes them bigger, but they just are. And then you kind of get so many of these being produced that they start to overspill. So in like in the early stages, the symptoms can kind of just be localized to like your anemias and thrombocytopenia and stuff like that, but then, and bone pain from the infiltration. But then as they start to leak out, they can start to deposit in other places. And then you've got these things called Auer rods, which you can see on the right side there, which again, like that's got a particular cause, but that is all you need to know, is like that's what you would see, that is unique to AML. And the prognosis for them sadly is generally pretty poor, but we still try and treat them anyway. So case 2, if it'll load, I know. So yeah, signs and symptoms that you tend to get in both, you're going to have those of anemia, so that's lethargy, shortness of breath when they're exerting because that oxygen delivery isn't what it should be, weakness, cardiac flow murmurs, bleeding, pallor, fever because you've got increased infections, petechiae, ecchymosis. You might get raised lymph nodes as well, but generally like you do tend to associate that a little bit more with lymphoma unless you're getting all these other symptoms, hepatosplenomegaly and bone pain from infiltration. And it's a bit of a paradoxical one because like, yeah, you've got white cells being raised, but they're those immature blasts that are just useless. So you're going to get this increased susceptibility to infection. Some investigations you want to do on your full blood count, you should see decreased hemoglobin, raised white cell count, reduced platelets. You want to be seeing blast cells in your blood film, and in bone marrow aspirate you can quantify this, and roughly you want to be seeing it, like they say above 20% is like your sort of cut off for distinguishing it from the myelodysplastic disorders we were talking about before. Do your lab cells to confirm the lineage, look for chromosome abnormalities, mutations. Your chest x-ray might show mediastinal widening, which again we looked at last week, and it's just basically saying that you've got stuff going on in the chest. It's not that the ribcage is getting wider, it's just like the cardiothoracic, like your shadow just is that more than 50% or whatever. It's, I think that's it. And you might get secondary pleural effusion, so that's common in all types of malignancy, to be quite honest. So, and then you want to do a few checks if you're planning to send someone in for chemotherapy or radiotherapy. There's a kind of a screen of things you want to check before, which we put in at the bottom there. So case 2. So we've got a 4-year-old boy with Down syndrome who presents with a month-long worsening history of lethargy, dyspnea, fever, and easily bruising. He seems pale and fatigued compared to how you'd expect a child of his age to be. He has a lot of bruising all over his legs, and you can feel his liver and his spleen when you are palpating the abdomen. Other observations you noticed are that he's got this generalised testicular enlargement for what you'd expect of a 4-year-old. And when you send off for a chest x-ray, it reveals multiple mediastinal opacities and bilateral pleural effusions. So some of that we've already kind of raised, but he's a 4-year-old boy, so we're thinking, okay, young patient, which population tends to get what this is going to be. He's got Down syndrome. We talked about the link with trisomy 21. Then we go on to talk about he's got some of the symptoms of the pancytopenia. He's bruising, hepatosplenomegaly, and then this generalized testicular enlargement is pretty niche. And then we talked there about the mediastinal infiltration. So this is a case of ALL. So this is the one that generally, like, it's very rare in a question for them to put it in the context of an adult because it's quite rare for adults to get it. But when adults do get it, the prognosis isn't good anyway. So it's the most common malignancy of childhood, particularly associated with Down syndrome or exposure that you might have had in utero to ionizing radiation, things like that. Whereas most leukemias tend to it tends to be more men that get them for whatever reason. This one is like roughly equally distributed amongst males and females. And what's unique to it is you get this CNS and testicular involvement. It is quite rare, but it leads to this testicular enlargement, which we saw in the case just then. And then you can get cranial nerve palsies as well, but again, they're pretty rare. And something else you can get is parotid gland infiltration. I don't know why particularly there, but it leads to like these swollen parotid glands, looks a little bit like mumps. And generally, because obviously you've got like the blood-brain reservoir and stuff like that, you're going to need to take into consideration like having to do intrathecal or intratesticular chemotherapy if they do have involvement of those parts. Because you've got patients, generally the rule with cancers is the younger the patient, the more curable it is. So that kind of applies with this, like the mortality from it isn't as high as with AML, but you do need to put patients on about 2 years of maintenance therapy once they've gone through that chemotherapy cycle. And like, just for a reminder, because if you're like me and you forget stuff like that, it's just like a reminder about what cells are in the lymphoid lineage, just to think like, okay, it's going to affect B and T cells. So there are B and T cell types of this, but they're not really worth worrying about. So case 3, we've got a 65-year-old lady who presents to the GP complaining of increasing tiredness. She's got this deep ache in her arms, legs, and she's bruising all over the place, but normally she doesn't get out and about much, so she's finding this to be quite alarming. She also recalls that her gums have been feeling quite sore, and she shows them to you and they look quite swollen. You examine her and you notice some painless cervical lymphadenopathy, and she herself has noticed this, but she hadn't noticed it, sorry. And when you auscultate the chest, she notices that the left lung base has crepitations. You send for a blood sample, and where you try and insert your needle, it starts to bleed a little bit. So like warning bells that are triggering here. We've got a 65-year-old lady, so older patient, signs of pancytopenia again, these kind of peculiar sore swollen gums, lymph nodes are all up. She's clearly got a pleural effusion going on, and then this kind of weird bleeding as well. So also what I could have thrown in there but haven't is like, because then it would probably make it a bit too obvious, is look for like, what they quite like setting questions where they'll show you like a a blood set of blood results that the patient had however many months ago, and then the most recent one. So it's worth looking, especially where AML is concerned, to see like, have they got a past report where it shows their blasts, like have they had like say 5% and they've just shot up to 20% or something like that, because then that, even if they don't specifically say, okay, they've got a background of a myelodysplastic disorder, because they're never usually like that black and white about it, you can build a picture in your head of like, okay, this has clearly been going on for a while, maybe it's making me think that they've got AML. So distinguishing features of this, AML is about 4 times more common in adults than ALL. So it's a disease of older people. Your median age for it's about 65. About 30% of cases will have had myeloproliferative disorder as a background. And you get these hour rods, which I showed you on the slide back at the beginning. Unique features. So you get these like weird violaceous lesions and the gum hypertrophy, which you've got pictures of over on the right. I don't entirely, like, the only way I can kind of understand that occurring is just to say that like the myeloid cells deposit when they sort of overspill from the skin. That's not a very technical explanation of it, so go and look it up if you want to, but that's like kind of how I sort of explain that in my head, but I don't entirely know why that happens. And you also get, with this particularly, disseminated intravascular coagulopathy. So if you haven't read about that, that's kind of where you get this ongoing, like, you clot loads, but then you use all your clotting factors, so kind of the opposite happens and you just sort of bleed everywhere. You'll come across it in stuff like when you do palliative and like general emergencies, but it's more unique to this in ALL, which is why we had the patient that was getting the bleeding when we were trying to do venipuncture on her. Generally, like, you can achieve remission, which is where remission just being where we've kind of like made the cancer so untraceable. It's not cured, but it's controllable, so to speak, in most patients under 60, and we'll cure about half of these, but generally the older the patient is, the less likely it is we're going to cure them. So poor prognostic markers include being a man, being over 60, it being a secondary disease, so secondary to a myelodysplastic, myeloproliferative disorder, having a high white cell count, and generally like the cell just having markers, which, like, we've not gone into the different types of markers because it's just too much depth, but having adverse markers, so to speak. So yeah, some quick things that can kind of make you think which is which. So our rods is going to be AML, lymphoblasts, IDOGI you're going to get, blasts you're going to get in both. Lymphoblasts you're going to get in ALL, and myeloblasts you would get in AML. Generally, like, your kind of weird, scary symptoms of the bony pain and the like feeling of fullness or pain in the stomach you're going to get with ALL. Organ infiltration you tend to get with ALL, but you tend to more get like skin and gum infiltration with AML. So just like, it's the silly little things like that you get with exam questions where they'll just like sneak it in and you won't even notice it because you'll panic reading through the question, but then it sort of answers itself for you if you know like the tips and tricks of how to spot it on an exam question. So how are you managing them? So generally, like, if you're thinking this is an older patient who isn't going to survive this, you're just going to palliate them on low dose chemo, symptom relief, so like painkillers, and giving them transfusions if they need them, antimicrobials to stop infections, or if it's curative, you're going to blast them with the high dose chemo. So you want to make sure you're avoiding anemia. So if their hemoglobin's dropping, give them repeated transfusions, aiming the hemoglobin over 100 grams per deciliter. Leukapheresis is a kind of a procedure that you do if someone's white cell count is really high and they're getting this thing called leukostasis. And it just means that it can cut the white cell count by like up to like 50% or something like that, and it renders chemotherapy more effective. Tumor lysis syndrome I go over in the lymphomas presentation, but you want to give prophylaxis for that. So that's stuff like rasburicase, allopurinol, making sure they're really hydrated. Hickman lines, because you're going to be like, your access is going to go in and out all the time. And something that you want to consider especially in younger patients, is fertility saving treatment, so sperm banking and oocyte collection, because chemo and radio can attack their fertility, sadly. And especially if these are young patients, that's, yeah, thing you want to think about kind of supporting the future as much as you can. So generally when you treat with chemo, you sort of start with this, what you call induction treatment, and then you move on to consolidation treatment. So when you use induction treatment, it's gonna that's gonna kill most of your tumor. And your consolidation treatment, you'll use slightly different agents, and that's just gonna like continue to cut the tumor down, but more slowly. If you think of that as being like the tiny little core of it, it just takes longer to get rid of. And again, you might use stem cell transplant, but it's like risks outweighing the benefits. And like long-term effects that you can get with this this kind of treatment regimen is heart failure, sterility, all different kinds of organ failure, neurotoxicity, and then secondary malignancy is sadly very common with it as well. So moving on to your chronic leukemias. So these tend to affect an older population, and this time we're not seeing blasts, we're seeing mature cells. And very often the thing that's kind of tricky about them, I think the acute ones usually are quite easy in a question to pick up on. The chronic ones can just look like anything else. So they're usually like asymptomatic until they get picked up on a routine blood test. So that tends to be a way that they're written about in an exam question and in real life. You usually get CML presenting in its chronic phase, and it tends to kind of target slightly younger patients, about 40 to 60. CLL is usually asymptomatic and discovered incidentally, and it's sort of with patients for a long, long time. And often patients will have these and they'll die of something else before they die of them. So yeah, they can present quite vaguely. A key thing with them, so when we're talking about blasts making your numbers of white cells shoot up, but they're being ineffective, so you'll still get more infections. Here, you're going to get raised white cells, but they're mature white cells. So you'll get this fever because these cells are still going to release interleukins and things that do cause you to have that. But you're not actually, there's like debate about this, but on the whole, you're not going to get patients presenting with like the mad amounts of weird infections that they do if they've got an acute leukemia going on. So nice little table again that kind of shows you a few differences between the two. So generally it's that Philadelphia chromosome is kind of key to CML, and you use a Coombs test in CLL because you get hemolysis with it for whatever reason. So they're the kind of the two main differentiators that I remember. Other than that, you can pause this and have a look at the table if you want to sometime, but I'll be going through it anyway. So case 4, we've got a 50-year-old male who presents to the GP with abdominal discomfort and fullness, a recent history of shortness of breath when he's standing up and he's getting out and around the house. So he hasn't really been doing much of this anymore. His partner's come in with him, who vouches that recently he lost quite a bit of weight, but he's put this down to feeling quite clammy and down in the dumps. On the other hand, it's been a long time since he recalls having an infection, even if he's been noting a bit of a fever for a while. So here, key things again, we've got a 50-year-old male, so sort of like older but not that old. Abdominal discomfort and fullness, recent history of shortness of breath, losing weight, and he hasn't had an infection, so like just what I was talking about then. So what we're thinking of here is CML to begin with. So CML is about 15-40% of all leukemias, tends to exclusively affect 40 to 60-year-olds. So I know it's not technically, but I tend to remember it as like CMLM for middle-aged-ish, because CLL tends to be older people. So tends to occur on a background of myeloproliferative disease. It is a myeloproliferative disease, but we'll be getting onto that in the next presentation. It's like almost always PH chromosome positive, which if you also see the words BCR, ABL fusion gene positive, that's the same thing. So the Philadelphia chromosome, because of that translocation, it causes those two genes to end up morphing together and being transcribed that way. And it kind of has 3 stages. So it's got this generally like asymptomatic chronic phase, and it can be like that for years until it actually kind of becomes anything. And then you get this accelerated phase where you tend to get all these like sudden symptoms, and it becomes hard to control. And then it may become something called a blast crisis, which is where it becomes most commonly AML, or sometimes ALL, or myelofibrosis, which is one of your other myeloproliferative diseases that we're going to talk about in the next presentation. So if you don't catch it when it's like that and treat it, you've only got, sadly, like a couple of years to live, as is the case with most of these, to be fair. So signs and symptoms of it: anemia, splenomegaly with abdominal discomfort, and that's actually your most common finding. So if you've got a case of 50-year-old person who's coming in, like in that last case we had, he was experiencing that abdominal discomfort of fullness, even if I didn't give you a lot of the other stuff that's in that presentation, that's in that case presentation, you could possibly have worked out what it was that he's got, if you were savvy enough about it. Weight loss, fever, night sweats, kind of like those B symptoms that we talked about with lymphoma last week. So a blast crisis, so we kind of talked about that a bit just then, basically saying that it's just when it kind of all of a sudden gets to the end of being nice and slow, building up a bit. There's a spelling mistake there, that should say bone pain. So it would present all of a sudden with like fever, bone pain, increase of like those pancytopenic symptoms. Your splenomegaly is going to get worse. You might get lymphadenopathy. And you might get these things called chromomas, or myeloid sarcomas, which are like just deposits. There's a picture of one there. Like if you Google it, the pictures are all like really vague, but just think of it as like lumps in the skin, I guess. Not very common, but associated with it all the same. So to investigate it on your full blood count, not RBC, normocytic normochromic anemia is how it would show up. Might be entirely normal, might have a raised white cell count, and your platelets normal low. If you go into that blast phase, then you'll notice like at least 20% blasts in your blood film, bone marrow aspirate, and stuff like that as well. So in a blood film, you'll find neutrophilia, elevated mature basophils and eosinophils. And if you see blasts, it's indicating that you've got the accelerated phase or a blast crisis. If there's about 10 to 19%, that's accelerated phase. About 20% is a blast crisis. You still want to do a bone marrow aspirate, and you're going to notice increased cellularity and more myeloid precursors. And then look for Philadelphia chromosome as well. This is the only leukemia where we've developed a specific treatment for it that works most of the time because of that Philadelphia chromosome, and that's imatinib, which is a tyrosine kinase inhibitor. So where that doesn't work, you'll just use other tyrosine kinase inhibitors, and if they enter the accelerated phase, generally you just use stem cell transplantation if, again, like the risks, the benefits outweigh the risks. Normal, like median survivability, about 5 to 6 years. Case 5, got a 70-year-old lady who comes in for routine blood tests and is found to have low hemoglobin, platelets, and a drastically raised white cell count. When she thinks about it, she does notice that she's been getting more tired than usual recently. And she started noticing that she gets a vague headache sometimes, but she's putting this down to old age. You run a direct Coombs test and this also returns positive. So things here that are flagging up for us: we've got a much older patient this time, coming in for routine bloods. She's got low hemoglobin, platelets, drastically raised white cell count. Getting more tired, this vague headache, a bit unusual, and then the Coombs test again. We didn't do that with the CML patient. So CLL is your most common leukemia, caused by clonal expansion of B lymphocytes, not generally T lymphocytes, and you especially find it later on in life. So as I said with CML, like that can be one of the distinguishing factors. It could literally just be like an age thing, and it's usually found incidentally. You might get the features of bone marrow failure. You might instead just get this localized disease of lymphomas, but quite rare for them to try and stick that in an exam question because you'd probably just confuse it for one of the lymphomas anyway. There is a pre-malignant condition for it. Wouldn't worry about it. I don't think I've ever seen it come up anywhere, but it's called monoclonal B-cell lymphocytosis, if anyone's interested. People tend to kind of live with it, and it sort of just gets monitored, like managed expectantly for about 10 or so years, because these patients are already so old anyway. So typical features: recurrent infections, anemia, painless lymphadenopathy, Fever, again, just because of your like these interferons or whatever that your mature cells are unleashing, not because of infection. Hepatosplenomegaly, but you'd more associate that with CML. Headache, cough, dyspnea. These all occur because you're getting this, like, because you've got so many white blood cells, they just cause this hyperviscosity, and then that's where you start to get like problems that are more associated with the blood supply due to that, as opposed to like lack of cells or anything. Something that's unique to this is it can undergo something called Richter's transformation, which is where it just becomes a diffuse B-cell lymphoma most of the time. Can also undergo Hodgkin's-like transformation, but you don't tend to see this as much. So investigating and managing this, differentiating it from CML a little bit, the white cell count tends to be very raised. And that's something that you look for, particularly with that, like that is one of the diagnostic criteria for it. On a blood film, you're going to get smudge cells, otherwise tends to look pretty normal. And for whatever reason, you can run a direct Coombs test and it should be positive if like it's more likely that hemolysis is going on. To manage it, generally, like there's a rule of thirds with it, which we'll talk about in a minute, but about 30% of them people you just leave, keep checking the bloods, make sure they're doing okay. If they start to get those symptoms of bone marrow failure, they do start to get infections because, okay, contrary to the thing that I was saying about you've got your raised white cells, so generally when it presents, people aren't getting more infections. It is still a malignancy, so it does it's a bit of a weird paradox that you are still more susceptible to infection because you've got a malignancy, because your immune system's it is a state of immunosuppression, but not, say, like to the extent you get with the acute ones. So if you start to get a patient that's getting recurrent infections, you're thinking this is getting pretty bad. If the lymphocyte count doubles in 6 months, if they're starting to get the systemic features, the B symptoms, and if hemolysis is present, then you're thinking, okay, we want to get them on some kind of treatment. So you might do some targeted chemotherapy, or if you're thinking this is an old patient, I just want to palliate them, consider things like steroids to mitigate anemia, erythropoietin, transfusions, therapeutic or prophylactic management of infections, allopurinol, rasburicase, or whatever you want to cover them with for tumor lysis risk, and that leukapheresis to reduce the white cell count. So about a third will just stay the same or get better or a bit better. A third will progress really slowly, and a third will progress quite actively. And they usually die either from an infection or because they transform over to the B-cell lymphoma, or from something else altogether. So cool, that is it for the first presentation. So if anyone wants to ask me quick questions about that, go now. If not, if people are still with me, I'll give us a couple minute break and then we'll start on the myeloma and myeloproliferative stuff. Does that sound okay? Don't know if anyone's still typing away.